The broadcast is now starting. All attendees are in listen-only mode.
Good afternoon, everyone. Thank you for joining us today. The series was made possible in part through the generosity of Amgen, and we thank them for their support. My name is Florencia Nachetto, and I'm the Senior Director of Health Initiatives and Education here at the American Kidney Fund. Before I turn this over to today's speaker, I'd like to direct your attention to the control panel you should see on your screen. All participants are on mute, so we won't hear you, but we welcome your questions. If you have a question, please type it into the section of the control panel called Questions. We'll see your questions and we'll do our best to answer them, either by replying to you directly into the questions box or out loud during the last several minutes of the presentation. This webinar is being recorded and will be made available for viewing on our website at kidneyfund.org/webinars within the next 1 to 2 weeks. For those of you in attendance who are health professionals, we're glad that you've joined us today, and we hope you'll recommend this webinar to the patients that you work with. However, as a friendly reminder, this webinar is not accredited for continuing education credits, and you will not receive a certificate upon completion. If you believe that your credentialing body may offer you credits for attending this webinar, we'll be happy to send you a certificate of attendance after today's session. Simply email us at education@kidney.org. Without further ado, allow me to introduce today's speaker, Dr. Clive Callender. Dr. Callender is Professor of Surgery at Howard University College of Medicine and founder of both the National Minority Donor Awareness Week and the National Minority Organ Tissue Transplant Education Program, also known as MOTTEP. In 1973, Dr. Callender helped to develop the first minority-directed dialysis and transplant center in the United States. Throughout the 1980s, Dr. Callender worked to increase the number of African Americans signing up to be organ donors, as well as to increase the number of African Americans who were aware of transplant as a successful treatment option. Building on this work, he founded MOTTEP, an educational program that helped to double the organ donation rates among minorities in less than 20 years. MOTTEP is now celebrating its 25th year of educating communities and saving lives through organ and tissue donation and transplantation. Thank you so much, Dr. Callender, for joining us.
Thank you very much. It's quite a delight to be with you today, and I'm going to try to present this topic in a way that you'll be able to understand and move along with me as we talk about what we first identified as ethnic disparities. And when I say ethnic, I'm referring to what people traditionally in older times would call race, and they talked about the white population, the black population, the Asians, the Native Americans, and Alaskan Natives, Asian and Pacific Islanders. And so we identified that there were 12 issues associated with disparities. And when we talk about disparities, just mean really the differences. We've learned that differences is what makes the human race so wonderful. And when we can value and appreciate our differences, we are the better for it. And so because of this, we've identified strategic plans so that we can eliminate the differences. When we talk about these differences, we recognize that we identified many differences earlier, as I mentioned, and now we've identified additional differences. And the problem is that these differences still exist now, more than 40 years after when we first identified them. Now, health differences in ethnic groups is something in the United States major sources of concern for at least the past 30 years, as the Secretary of State Heckler identified in 1985. I first became aware of these differences in ethnic groups and transplantation itself more than 40 years ago. And it's been interesting over the years and decades to watch how things have changed or stayed the same. Now, one of the things that has not been attractive or people have not paid much attention to is the fact that gender is an issue. So not only is the ethnic issue a concern, but also is the differences in gender. And few are aware of the gender along with the age differences as they relate to end-stage renal disease and kidney transplantation. And the goal of this presentation is to educate all of you on all of these matters. And at the end of this presentation, I will hope that you will be able to identify what are the additional steps that are necessary to eliminate these transplant health differences or disparities, as we call them, and identify which of the 17 differences or disparities that we've talked about that have been narrowed or eliminated, and to also emphasize the importance and value of fighting political battles from within to make a difference that must be made. And to call your attention to the fact that while female gender is a positive for health in general, and longevity in females is evident in most countries, however, in end-stage renal disease and kidney transplantation, there are some negative connotations that we will discuss. I will also emphasize the importance and the wisdom of the majority-minority community education and empowerment, meaning going to the community and getting the community to take charge of the issue and make a difference. And we've identified that this is probably the most powerful step in a strategy to narrow or eliminate all of these differences that we've identified. Now, as I talk about these differences, one of the things that I've identified and appreciate is that racism is an issue. Now, while racism is an issue and continues to be an issue, the use of the term race in science could be one of the first things that we should do to eliminate or narrow these differences between the white and black populations and the majority and minority populations. At least in science, that term should be replaced with ethnicity or race/ethnicity in all of the scientific journals, with UNOS, with the Census Bureau, and with the federal government as well. So that one of the first things I think we ought to do is to eliminate the term race in science. Second, and this is an issue, is that there's a 10 to 20% poor graft or kidney survival rate in the African American population when compared and contrasted with the white population, the Latino population, Hispanic population, and the Asian American population. This is interesting because of all the populations, the Asians have the best survival rates, but the African Americans have the poorest survival rates. And further research, we think at least $1 billion should be spent to try to identify why this poor graft or kidney function survival rate exists. Now, just to share with you some of the data, information about African American ethnicity and kidney transplantation. African Americans continue to have a 42% high risk of kidney loss 5 years after kidney transplantation. Functional survival kidney grafts in African Americans, or losing the kidney, occurs in 50% more than any other ethnic group. And this problem remains now some 40 years after it was first described. In general, African Americans have better outcomes when you have the very powerful transplant medications like tacrolimus, FK506, CellCept, and steroids. These are medications that transplant patients are well aware of, but these powerful medications work better in African Americans than with other ethnic groups. Success in transplantation requires probably the individualized approach to immunosuppression, the so-called precision medicine or personalized medicine, which is true not only for African Americans, but all ethnicities. Now, you've heard the term social determinants of health, and we're talking about patient-specific risk factors such as age, other diseases, and economic status. And then the second bullet on this slide talks about the genetic differences that we're now finding and the way in which drugs are metabolized differently in different ethnic groups, especially in the African American ethnic group. And we are identifying on this slide that African Americans require more anti-rejection medication than other ethnic groups in order to get graft survival. Also, the CellCept drug is more effective at reducing acute rejection in African Americans. Also, the incidence of acute rejection is low in African Americans when tacrolimus and special treatments are used, more important for African Americans than in whites or other ethnic groups. And that was the second difference that we identified. The third is that the transplant waiting times for African Americans is twice as long as it is for whites. And there's a new change that has happened. I have a fancy name for it here, the Eurotransplant model, but what it does, it says that regardless of when you get on the transplant list, that your waiting time begins when you start dialysis. This is something that is new and just started in some centers in 2014 and in others just in October of last year. And this will perhaps reduce that waiting time so that the waiting time for whites, blacks, and Latino, Hispanics, and Asians will be the same. So this is a major breakthrough in waiting times that is new and will make a difference for all ethnic groups. Now, the higher prevalence and incidence rate for kidney failure, which in blacks is 2 to 4 times more frequent than it is in whites, is something that we've observed for at least the last 30 years. And so far, we haven't changed it. But there are things that we can do: stress reduction, exercise, proper nutrition, and the Love Yourself, Take Care of Yourself program in all communities. This is what we think is something that needs to be applied on a major basis to change this difference in transplantation that we've observed. The fifth difference or disparity is referred to the fact that African Americans and other minorities are referred for dialysis and transplantation 12 to 18 months later than the white ethnic group. Meaning that when you get on dialysis, sometimes in some centers, they don't even give you the option for transplantation until 12 to 18 months after white groups are given that information. And it's important, therefore, to overcome this, to have that model that we talked about, in which as soon as you get on dialysis, that your waiting time for transplantation begins. And because of this, we've identified changes already so that the waiting time is narrowed, and so is the time in which minorities are referred for dialysis and transplantation. When we say referred, we mean that the doctor tells you that you can get worked up for transplant and you can have a transplant as soon as possible. This, in the past, has been different between blacks and whites and Latino, Hispanics, and other ethnic groups. Now, this is a new term for you, this slide, the green screen. And the green screen is something that I named many years ago because I looked into the information on why African Americans, for example, were not listed for liver transplantation. And to my amazement, I found out the reason was they didn't have the green. And when we say green, we're talking about money. So that for extrarenal transplantation and for some renal transplantation, if you weren't insured, you didn't have money for transplantation, then you died. You didn't get on the waiting list, and if you didn't get on the waiting list, you died. Now, for kidney transplantation, the beauty about dialysis is that for about 95% of the cases, we have insurance that will cover, and so you can get on dialysis. And so the green screen, or the fact that you're underinsured or uninsured, really doesn't play much of a role, but it does for liver transplant, heart transplant, and lung transplant. And so the green screen is something that has been minimized for most of you dialysis patients. 95% of the patients on dialysis have insurance of one kind or another. Now, how can we eliminate this? We hope that you and I can find creative ways to enable the under and uninsured patients to get on dialysis and also to be transplanted. Now, this is something that this slide talks about, the fact that patient survival rates on dialysis are superior for whites than other ethnic groups. Recently, in the 2014 data, we found that yes, African Americans still have better survival than whites, but now Native American and Latino Hispanic patient survival rates are superior to those of African Americans and whites, so that the way to equalize the kidney transplant rates is to have more African American dialysis patients be transplanted, and that is something that we have to work harder on doing. Now, the organ donor recipient disparity is now over 90,000, and because of this, more than 20 people die every single day waiting for a transplanted organ. And this fact is unchanged except in the African American population. And you may wonder why. Why is it that in the African American population things are different? Well, let me share some interesting facts that we've identified. In 1982, minorities represented more than 50% of the transplant waiting list, but only 15% of the donor populations. As a matter of fact, at that time, African American blacks were thought not likely to donate, and donated only represented 3% of the donors then. Let's look forward to now, 1995 and 2010, and to our amazement, African Americans, when compared and contrasted with other groups, are the #1 ethnic group in reference to organ donors per million. A dramatic change that we're pleased to participate in. Our MOTTEP sites, as you can see in this slide here, are perhaps a major reason for why this has occurred, in addition to the fact that we were funded by the National Institutes of Health for 10 years and received some $15 million to identify MOTTEP sites that have, because of their efforts, the National Minority Donor Awareness Week, the community education and empowerment that took us away from awareness to action and accountability. These have all contributed to increased and sustained donation rates. I think I've stated that the blacks now rank above all other ethnic groups in organ donors per million within the United States, which we are very proud of. But we believe that a lot of it has to do with the fact that we have actually had a grassroots face-to-face presentations along with media reinforcement, which allow for donation rates to be increased, not only increased, but also to be sustained. We also believe that part of the problem may well be the emphasis on social media, with the exclusion of the face-to-face interaction, may partially explain the decrease in other ethnic groups that you saw on the previous slide. Now, the ninth issue is a genetic issue that we've identified. We now, because of the human genome and our research, have identified that there are genes that are found in African Americans that are not found in other ethnic groups that may be responsible for why we have more kidney failure in African Americans than other ethnic groups. Now, item number 10 is a problematic slide because it talks about the fact that we have poor graft survival of African American kidneys and other organs when they are transplanted into African Americans and whites. And why this occurs is something we don't understand. We need to do more research, and that $1 billion we talked about that is necessary is especially applicable to unraveling this mystery. And I'm sure there'll be questions about why this is a fact, but it is a fact that we identified several years ago. Number 11 is eliminating inequitable allocation. What does that big fancy word mean? It means that if an organ becomes available, that it should be available to anybody on the list, regardless of ethnicity, ability to pay, or anything else like that. And that model that I talked about earlier, the Euro transplant model, that makes transplantation waiting time begin at the time you get on dialysis, will allow us to become more close than ever to having the so-called equitable allocation, because we are now having more equitable allocation than ever in our existence. And I'm thrilled that things have changed, and that in my lifetime things have changed. Now, this is probably one of the most disturbing aspects of my presentation: institutionalized racism. And all that is talking about when I say that big fancy word is that the superior-inferior race concept has to be done away with. All of our ethnic groups are wonderful. They have strengths and they have weaknesses. And what makes the human race so wonderful is the fact that we acknowledge these differences and use these differences to help us be the best that we can be. Now, however, because of racism, this is an obstacle that has to be overcome, and using community education and empowerment is perhaps one of the major keys to overcoming this. Now, the unique post-transplant drug responses, for example, I've put on the slide that blacks on Prograf have twice the incidence rates of diabetes than whites. And these unique post-transplant drug responses are not limited to just that drug, but we find that in other drugs. And we need to do more studying to find out why that is and see what exists in other ethnic groups that are comparable. Now, this number 14 is a slide that disturbs me more than any other slide that's in this presentation. And it says here, and this is a fact, black kidney donors represent 13% of kidney donors. But they represent 40% of the donors who, after kidney donation, require dialysis and renal transplantation. We need further research and analysis to understand why. But this is a disturbing fact that we don't understand, but we need to do as much research as we can to get the answer to this one. Now, I'd mentioned earlier the fact that gender disparity is an important problem. Now, what I don't say on this slide, but I think I must emphasize, is that when we look at who are the most common live donors, male or females, tragically I have to confess that women are the most likely donors and males are the most likely recipients. That's a topic that offends me a bit as a male, but it's a matter of record. And there are other issues about gender that become important. We understand now, because of research, that sex differences do affect the outcomes of kidney transplantation. That females, as compared with males, have a 10% increased odds for acute rejection during the first 6 months after transplantation. However, they have a 10% lower risk of graft loss for chronic graft failure than males. And they have a greater reduction in the risk of chronic graft failure when CellCept, a transplant medication, is used when compared with men. Other research done by others have shown that these differences in drugs and the metabolism rates, which is different between men and women, becomes critical. And we need to further elucidate why these sex differences occur. There is a lot of recognition now that a lot of the research that was done earlier was done in males and wasn't done in women. And we also now understand that the sex differences are important because the female, the XX chromosome, may be superior to the XY chromosome, and the females may be superior to males in many regards. This, however, the essence of this is to speed up the individualization of treatment for transplant outcomes, meaning that whether it's a male or female, whether it's an ethnic group that's different, we need to personalize our way in which we individualize transplant outcomes. Now, non-compliance, which means that you don't stick to the regimen, you don't get dialyzed when you're supposed to get dialyzed, you don't take your medication when you're supposed to take your medication. It used to be said that blacks were more non-compliant than any other group. We now know that the group that is more non-compliant than any other group are the younger patients less than 20. And those patients with lower income are the groups most likely to be non-compliant, not ethnicity as an issue. Now, this is something that is relatively new in terms of our appreciation for differences in transplantation. And this is ageism, and I know ageism is something that's a term that isn't commonly used, but it is to identify some very interesting data that has been unmasked. For example, this slide says donors aged greater than 50 has increased by 200%, and donors aged less than 50 has decreased by 76%. And the standard criteria, meaning donors that are normal and have no unusual aspects, are now less than 50% of donors, meaning that most of the donors that we use now are from older patients. And as donors' age increases over 50, the rejection rate increases. As the recipient age increases over 50, the rejection rate decreases. Amazing findings showing that age is an issue and age differences matter. Why? And this slide kind of answers the question why. As donor age increases, so does the ability of the kidney to produce rejection, an increased incidence of rejection. Whereas older donors' kidneys actually exert a more vigorous immune response, causing rejection. On the other hand, older recipients, that's the last bullet on the slide, release more suppressor cells, and therefore they are less likely to have rejection. So if you have an older donor, the likelihood of rejection is greater. If you have an older recipient, which means that somebody is older, is less likely to have rejection than a younger person. Now, why does that happen? A lot of it is requires more research, but the bottom line is, as the age of the donor increases, the immunogenicity, or ability to increase the incidence of rejection, increases. As the age of the recipient increases, on the other hand, the likelihood of transplant rejection decreases, and tolerance, or the ability to accept the organ, increases. Now, these are some of the interesting factors that we've identified as we try to look at what is the reason why all of these differences exist and what we can do to make the changes. And the bottom line for much of this is that we have to have community education and empowerment, taking the problems to the community, letting the community become the change agent, so they know all of the facts and they take the facts to the community and help the community help us with the actual solution. Now, when we talk about that kind of solution, I'll show you here the so-called Be Blessed model that we've created, which really emphasizes the ability of loving yourself, take care of yourself, and emphasizes spirituality and stress reduction as a way of overcoming all of the issues that result in us having so much end organ failure, whether it's the kidney, the lung, the heart. And this is the final slide that I have, which identifies the organ donors per million from 1999 to 2010. This is my last slide, and this presentation is now open for any questions that you may have.
Thank you so much, Dr. Callender. It was a really good presentation, very informative, and we did get actually several questions. from the folks that were listening today. So the first one, have faith-based initiatives been used to get the word out to take charge of their health? Would programs at churches help? If so, how?
I'm so glad you asked that question, because the organization that we founded, MOTTEP, the National Minority Organ Tissue Education Program, which celebrates its 25th year of existence this year, actually that is what was its principal modus operandi. We started all of our efforts in the churches, and the success of our program relates to the fact that who makes up the people in the churches that make the difference? Women. And who is the group in the community that has the most influence? And the ministers. And so going into the churches, the faith-based efforts, going to the pastors and the women, has made a difference. That's opened the door, that has allowed us to be successful and to have a grassroots program that actually allowed African Americans to become donor ethnic group. So faith-based initiatives probably are one of the most important aspects of community education and power. Not the only one, but they have been the key to our success, is going into the churches, educating and empowering the people in the churches, who then go into the community, who educate and empower the community to make a difference. In these efforts, you asked how did we do it? We actually got funding from National Institutes of Health to create MOTTEP sites in some 15 places across the United States. Once we went into the 15 sites, we then actually had funds that allowed the community to identify a person who then organized that community. That community then identified ways in which it felt the message should be taken to the rest of the community. They then were able to identify the appropriate messenger and the appropriate mission. And this then really has been the reason why our results have been successful. Recognize that we must go from awareness to action to accountability, and emphasize that we must love ourselves, take care of ourselves. Some of the things that we did in the community, we emphasized the importance of exercising 30 minutes a day, at least 5 days a week, getting your blood pressure checked after the age of 12, because in many ethnic groups such as African American, Latino, Hispanics, we develop high blood pressure very early. Eating the right foods, eating more vegetables, more fruit, less red meat, more fish, eliminating smoking and addictive drugs, trying to keep your weight down so that your BMI is about 30 or less. These are all things that we did in the community to educate and empower them to love themselves, take care of themselves, and help us reduce the incidence of kidney disease.
Great, thank you. And actually, you mentioned the Be Blessed model. We wanted to know, is that the same thing as the Love Yourself, Take Care of Yourself program, or are they two different programs?
Well, actually, what happens is that the Be Blessed model, I guess I'm going the wrong way. The Be Blessed model is a model that we developed as part of our efforts to get the community to understand that if you loved yourself and took care of yourself, that the likelihood of you getting some of these diseases, the hypertension, the diabetes, and cancer and other illnesses, was decreased. And if you look at this slide I put up again, which talks about the biology, the environment, your belief system, your lifestyle, your experiences, your spirituality. Sometimes we don't appreciate the importance of meditating for 30 minutes a day, 5 days a week, about the same time as you exercise, because spirituality and stress, all of these are aspects of how the application of love yourself, take care of yourself, and the specific Be Blessed model will help us to lose the race from the kidney to the grave. One of the problems with minorities in the past has been that we win the race from the cradle to the grave. We want to lose that race. We want to come in last. And loving yourself, take care of yourself, and applying the Be Blessed model will help you do just that.
Great. Thank you. So what are some things that patients can do to continue the progress that has already been made?
Well, I think one of the most important things is to communicate among your family about ways in which they can do the healthy things that make a difference. One of the things that bothers me more than anything else is the fact that often we don't get our blood pressure checked until we're in our 20s or 30s or 40s. And if we get our blood pressure checked, we don't take the medicine that the doctor recommends that we take. I think that hypertension and diabetes are the two commonest causes of kidney disease. And so diabetes, if you get a urine sugar test or blood sugar test, you can find out early and then take the medication that treats diabetes so that you can prevent kidney disease. Hypertension, similarly, if you get your blood pressure checked early and you then take your blood pressure medicine as the doctor tells you, if you look at your salt content and reduce your salt content, if you, as I mentioned earlier, if you really exercise 30 minutes a day, at least 5 days a week. Now, if you exercise more than that, it's better for you, but that's the minimum. I will repeat the importance of decreasing the fried and greasy foods, the fried foods, trying to eat more vegetables, eat less red meat, more fish. So these are the things that you can do. Some things about the environment you can't change, but the things that we've just talked about, I think, are things that we can do. For example, dialysis patients, I think it's important for them to actually take their dialysis treatments very seriously and follow their diets appropriately. It's also true that doing the things that I've mentioned earlier will keep them from getting high blood pressure, diabetes, and obesity, the things that actually cause you to have kidney failure in the first place.
Okay. Here's another question. Does research explain why younger people are at higher risk for kidney rejection compared to older people?
A very good question, and one of the things that was amazing to me that was unmasked as we looked at the 10-year data is that when you think about it, the younger people are stronger. So that means their immune system is stronger. And if your immune system is stronger and you get a transplant, that means that you're better able to fight off the transplant. Now, on the other hand, if you're older, your immune system is a little weaker and you're less able to fight. And therefore, the transplant medication works better. So to simplify it, basically, the younger you are, the more important it is to have transplant medications that overcome the immune system. Now, I think that should answer that question. Of course, the other question that is implicit is, why is it that the older kidney is more likely to cause rejection if it goes to another person? And there's some studies that have identified that there are products from the older kidney that result in enhancement of the rejection phenomenon. Now, I must add, we have not studied that problem adequately to get any better answer except to say that there are products that are elaborated. However, if we do the correct research, we can probably find out how to overcome it. But anyway, it is a truism that the older kidney is more rejection prone, and the older recipient is less likely to have rejection than the younger patient.
Okay. And another question here about the role of the church. So the church used to tell us that our body should be intact when we pass away. Is this belief changing as a result of better health communications about being a donor?
Well, one of the things that when we first started our efforts was going to the church to recognize that religion was very much in favor of donation, and that emphasizing that when you leave this earth, that your soul will transition, but your body will go from dust to dust, from dust to dust, and so your body is destroyed. But your soul is on. So the best thing that you can do, and the church now is emphasizing this along with us, is to, in life and after death, leave organs and tissues so that others may have a second chance at life. The blind can see, the deaf can hear again, the lame can walk again, and those who would otherwise die will have a second chance at life. And the church is recognizing this more than ever. There was a time when people would tell me that I want to have all my body parts when I go, but for what cause is that? When you go, it's a new body, a new life, a new heaven, and a new spirit, and so that old things are passed away, and that old body of yours is gone. And so the church is now more than ever before is emphasizing the fact that it is in giving that you receive. It's in pardoning that you pardon. It is in dying that you're born to eternal life. So it is the right and religious and the best thing to do, to give organs and tissues in life and after death. Because when you go to the pearly gates, St. Peter may say, you know, the reason you're here is because of that great thing you did at the end of your life. And giving organs and tissues to others would have a second chance at life.
Thank you, Dr. Callender. That was very nice. As a person of color who received a kidney transplant, what is the best way to advocate for patients in my own community?
One of the best ways is to go back to the dialysis unit and let them see how good you're doing, and let them know that they should take a chance and have a transplant, because it is clear that the lifestyle and the longevity of life is greater after a successful transplant. So yes, you can go to the community, but the community that you used to belong to on dialysis is one of the first places that I think you should go. Then after that, go to your community and be available for groups like this one and others to go and talk to the community about what a difference the transplant has made for your life.
Okay, we have lots of questions. One more. Tell me a little bit more about FSGS and its role in kidney transplantation.
Oh, how about that? I thought that might have been too complicated. But that's an interesting, we've done a lot of research on that now. And, you know, genotyping and precision medicine and genetics is very important now. And FSGS is something that is more common in the African American population. And it's also more likely to recur after transplantation. We now know that it occurred as a consequence of genetic differences that were put in place first in Africa to protect us from sleeping sickness. And this virus that was protective against sleeping sickness has predisposed us to this kidney disease. And this may well be the reason why African Americans have more kidney disease than any other ethnic group. Now, in addition, FSGS is also the disease that causes kidney disease when you have HIV. And HIV disease, as we now know, is one of the commonest diseases. But the kidney disease that you have when you have HIV is more likely to be FSGS than anything else. And it occurs in 94% of the cases in African Americans. And so it's important to know that FSGS is common in the African American population. And when you need a transplant, sometimes because it is genetically determined, it may well be that sometimes the best donor for you may or may not be one of your relatives.
Okay, and it looks like we received a question from a social worker, which is great. And her question is, how can dialysis center social workers and other healthcare professionals partner with MOTTEP to engage our patients their families and communities. I see print materials are available. Are there other ways that we can partner or engage?
Well, I think one of the things that we emphasize is the fact that, yes, social media are important, but yes, print information is important because we know that 25% of the United States is not computer literate. We now know that approximately 40% of patients on dialysis are not using their computers. So we still need that grassroots effect, that face-to-face effort, that community education and empowerment. So my comment is the more social workers, the more health professionals are willing to go into the community and educate and help us with the grassroots face-to-face effort, the better off we are. And the more likely we are to have the miracle that occurred with us with African Americans and donation apply to all other ethnic groups. One of the things that we don't talk much about is the fact that in order to get these materials, you need to have funds. In order to go in the community and educate and empower, you need to have funds. And so one of the things that we don't talk much about, but probably is more important than almost anything else we talk about, is the fact that we need to have more funding to allow us to get more people to go into the community, to educate and empower, to make a difference, especially since we now know that one of the most effective ways of changing community behavior is through the community education and empowerment of that community.
Okay. And it looks like one more has come in. What do you see as the next steps in the movement to reduce transplant disparities across the board?
Well, I would say that what a great question.
Very good question.
Yeah, it's almost like I planned it that way. I think after all is said and done, what I have always felt is that fighting from within is the best way to do it. You know, I've been an African American transplant surgeon, and I've seen many things happen. One of the things that I'm most impressed with is this point that I emphasized about the change in equitable allocation. Once we have equitable allocation, we can all go to all of our groups and say, listen, everything's fair, everything's equal, and therefore all of us have become part of the solution to the problem. And as I look at this, I think education is the key. Education is powerful. And going to community, educating and empowering, getting the message out by social media, by print media, by grassroots face-to-face efforts, communication and empowerment to me is the key. But by whatever means you need to do that, I think we need to do it. I think the greater message that I have is that it can be done. And why do I say it can be done? Because it has been done. And I think what we've demonstrated with MOTTEP is that here's a group of African Americans that were 3% of the donors when we started in 1982. And here we are in 2016, and they've gone from the bottom to the top. And primarily because we're going to the community, educating and empowering that community to become part of the solution to the problem. And so, to me, one of the most powerful things you can do is to take what we have, share it with community, get them to take the message and effectively change behavior, because that's what it's all about. Initially, people said behavior will not change. Well, we've demonstrated behavior will change. And so let's empower our communities to make the difference that must be made.
Well, thank you so much, Dr. Callender, for coming here today and talking to us about your experiences and raising awareness about transplantation disparities. It was a great honor to have you here to speak to our patients and to talk about this very important issue. As you can see, they were very interested, lots and lots of very great questions, the most we've received to date. So again, thank you from the American Kidney Fund for spending the time here with us today.
Well, thank you, and I hope I got the message across to our population. The challenge was to get the message across effectively, and I hope I have done that.
Okay. Okay, well, our next webinar will be held on Tuesday, September 20th from 1 to 2 p.m. Eastern Time, and will be about preparing for emergencies or disasters with kidney disease and using the Kidney Community Emergency Response Coalition, or CAESR, as a resource. This webinar will be led by Peter Traub, Associate Director of CAESR, and Beverly Whittet, CAESR Coordinator. Both Peter and Beverly have extensive experience in the end-stage renal disease emergency preparedness field. Registration is open now, so please visit kidneyfund.org/webinars for more information and to register. When the webinar closes, please do not close your browser window. You may see a pop-up saying that the webinar has ended. Please close that pop-up and proceed to the webinar evaluation survey. Your honest feedback will help us make our webinar programs the best that they can be. And from all of us here at the American Kidney Fund, thank you so much for spending the hour with us today. Thank you again. Bye-bye.